Okay, everyone, we're starting off with the big one. We're probably starting off with the biggest one here for rotator cuff repair. Whew, there's a lot that can be said about rotator cuff repair, and there's a lot of new research even that's come out in the last couple months that's not part of this slideshow, but I'll talk about it a little bit. So let's start off with the anatomy like we normally do. So again, just kind of familiarizing yourself with the shoulder. So we've got, this ball and socket joint that's not terribly stable. So you do have a good number of ligaments that surround a labrum. So remember that labrum's like a little rubber band around the joint. And then you have your ligaments. Keep in mind that we have kind of that space between the coracoid process and the acromion that has that ligament there that we're going to have the rotator cuff kind of coming through there, the supraspinatus muscle coming through there. And then we have our bicep tendon and the bicep tendon sheath. And remember that the tendon goes through that bicipital groove and kind of attaches then deep in the ball and socket joint. So here's another picture that starts to show the rotator cuff. And this is kind of a picture laterally. So if you were to look at the shoulder from the side, if you look on the left side, you'll see there that bicep tendon again, and you'll see where it goes into the glenoid. And then kind of directly in front of it, but then it kind of goes behind and attaches onto the humerus is the subscapularis. So that subscapularis, remember, is going to kind of sit on the anterior portion of the scapula, well, kind of anterior, and it's going to kind of come around and attach onto the inside of the humerus. And then if you kind of look on the top there, you'll see the supraspinatus, and it travels through that subacromial space. And that's where we know there's lots of things that can happen in that subacromial space that can lead to pain. And a tear obviously can cause some problems as well. And then just posterior to the supraspinatus, we have the infraspinatus, and then the teres minor. So they're all attaching onto the humerus. To the right, you'll see that we have some bursa. So that's kind of showing picture where you've got the muscle attachments, but then you also have some bursa. Bursa can get irritated. We talked about how there's bursa often when you've got some tendons that are rubbing against bone. And so we can get bursitis definitely in the shoulder, just like you can get in other parts of the body. And so that those bursa can get irritable, especially the bursa in that subacromial space. And so when we talk about the rotator cuff, we're talking primarily about a group of 4 muscles. So the muscles that do external rotation are the infraspinatus and the teres minor. And those 2 are along the posterior aspect of the scapula. You can see those there. And then, like I just said, they're going to attach along the humerus, the proximal humerus, kind of somewhat posteriorly. And their primary goal is external rotation. So you've got those 2 muscles. The posterior deltoid also helps with external rotation a little bit. Internal rotation is done by the subscapularis. And so the subscapularis, like I said, is kind of along the anterior aspect of the scapula there and attaches onto the humerus. Internal rotation also has a bunch of other big muscle groups like the pec major, the latissimus, and the teres major that work with it. So you have some big muscle groups that are doing internal rotation, some smaller muscle groups doing external rotation. And so that can cause some problems with muscle balance, which, as we're going to talk about, is usually the reason why we end up with rotator cuff tears. Unless there's a traumatic injury, it's usually because muscle balance is not very good. And so we end up causing tears to certain muscles of the rotator cuff. The other muscle we have to think about that's part of the rotator cuff, well, there's 2 really. One of them is the supraspinatus. So we talked about how that supraspinatus goes through that subacromial space and attaches. Supraspinatus' primary action is going to be scaption. So that scaption movement is a kind of a combination. It's the halfway between flexion and abduction. And you'll see how the supraspinatus comes down and attaches onto the humerus. It kind of pulls the humerus in and keeps it nice and stable there while we're lifting our arm. And the other thing I want to point out in the picture to the right is we have that long head of the bicep, and we don't necessarily consider that part of the rotator cuff, but we do recognize that it is affected when the rotator cuff is not working correctly. And sometimes the long head of the biceps can also have its own tendon issues. And so when doctors go in to do surgery for the rotator cuff, they may end up having to either repair the long head of the biceps or do some debridement around that. So there's definitely situations where not only are you getting a rotator cuff repair, but you're also going to be affecting the long head of the bicep. So keep that in mind. Make sure you recognize that. You can see the op notes and recognize whether or not the long head of the biceps is also included in the surgery. So this is going to be, we're trying to give you some good imaging things here so that we all know that our patients love to to provide us with their imaging and say, well, what does this mean? What is this saying? And so you can see here that we have number 1. So this is the posterior shoulder. Number 1 is where the infraspinatus. Okay. And then to talk about the teres minor is just below that at number 2. So that's, again, another part of our rotator cuff. The subscapularis is number 6. So you see it's kind of coming around, again, more anterior and then to the medial aspect there. And then the long head of the biceps is number 8. So I just want you to really recognize those. Those are the most important thing. Obviously, number 4 is the humeral head. So that's important. And then number 5 is the glenoid. So again, that ball and socket joint, there's our ball and socket right there. You can also see a little bit of the labrum in this picture. So that's going to be 7A and 7B. And you can see that the labrum, like I said, is kind of like a rubber band. It's not very stable. It's not a big thickened connective tissue. It's relatively, it's not very thin, but it definitely doesn't provide a huge amount of extra surface area to allow for good movement, right? We need to have lots of movement of the shoulder, but it doesn't allow for stability in the same way that maybe a labrum of the hip might do that. So looking at this one, you're going to see, again, I just kind of want to point out the rotator cuff primarily. So again, number 2 is the humeral head. And you can see the supraspinatus tendon is number 3. So it's just coming down along that lateral side and attaching onto the humeral head. The infraspinatus is more posterior. You'll see that. And then the teres minor, like we talked about, is number 5. So infraspinatus is number 4 and teres minor is number 5. Subscapularis, again, is anterior. So that's going to be number 6. And then biceps tendon is coming in at number 7. And again, I don't know how helpful it is to orient yourself to all of these, but I think it can't hurt anything because, again, you're having patients who probably are seeing, they're showing you lots of MRIs. So again, number 3 is the humeral head. So that's important to orient yourself there. And then if you look at the top, number 9 is that supraspinatus. And then if you look kind of down to the big muscle in the middle there, that's number 4. That's your subscapularis. So that's the anterior aspect of the scapula. And then let's see, what else is really important for you guys to be able to see. We talked about the supraspinatus tendon. And I think that's probably the most important things to see here. Okay, so now that we're past kind of the anatomy reminder, little review, let's talk about rotator cuff tears. When do we see them? It can be an actual injury itself, or it can be an overuse type problem. So for anybody who's doing a lot of overhead stuff, so overhead sports, those are obvious ones where we can see more significant tears, things like swimming, tennis, you'll see in the picture, badminton, those kinds of things. Sometimes pitchers in baseball, American baseball might have it as well. The most common thing to tear is going to be the supraspinatus. So Supraspinatus, 72% of the surgeries that are done are supraspinatus tears only. Okay, so this is where we're going to see problems. And if you remember back to the anatomy, it makes sense. It's moving through that subacromial space. If that space can't keep its space, if there's compromising of the space, then you're much more likely to end up with a tear of that tendon. Also keep in mind that it's usually older people that tend to have these huge amounts of tears. So if you remember when we talked about just the tendon pathologies in general, we said that as we get older, our tendons don't have the same integrity, so they're not quite as strong. And so a lot of people, 28% of people over the age of 70 probably have some tear. And, you know, it gets up to 38% over the age of 80. And I've seen even numbers bigger than that. But you have to keep in mind that a lot of them don't have any symptoms. So if they have symptoms, we need to treat the symptoms, but it's unlikely doctors are going to do surgery at that age for a rotator cuff because the rehab can be pretty extensive. So you just kind of have to keep that in mind that that you're going to see patients with tears. You're probably not going to be recommending surgery for them. And then if the patients happen to be over the age of 60 and they dislocate their shoulder, they're probably very likely to have some sort of tear, right, of some part of the rotator cuff. So just recognize that dislocations when you're young probably don't tear the tendons. It probably just messes up the labrum. But when you get older, you're more likely to have tears in the tendons as well if you have a dislocation. So as we said, 4 tendons, 4 muscles. We've talked about the muscles here. Sometimes bicep tendon is affected as well, and it could be part of the surgery. We classify the tears obviously by size. So a small tear is going to be up to 1 centimeter. A medium tear is between 1 and 3 centimeters. A large tear is 3 to 5. And a massive tear is over 5 centimeters. And this is important. You will see as we go through the rehab part of this that we separate it out with small to medium tears and large and massive tears because the rehab is slightly different. The time frame essentially is different. The rehab itself is not that different, but you need to know the size of the tear because it does affect how quickly you move through their rehabilitation. So again, as I said earlier, for the supraspinatus tendon, not only does it have kind of a disadvantage anatomically because of that subacromial space, but also it doesn't have the best blood flow near the insertion. So we've talked a lot about the fact that blood flow is so important in that area right where it attaches onto the humerus. The blood flow is not very good. And so we're more likely, if we get little micro tears, for it to tear and stay torn because the blood flow isn't as good to help with the healing process. So we diagnose this in multiple ways, and I think you guys have done a lot of assessment, hopefully, of shoulders, and so you probably have seen the tests that can be used for diagnosing a rotator cuff tear. What's important to keep in mind is that passive range of motion is usually totally fine. Some patients, as you guys have seen, who are older, who maybe have had shoulder problems for a long time, they may end up having a little bit of a frozen shoulder, so decreased passive range of motion, but that's just because of their inactivity, not because they actually have a diagnosis of frozen shoulder. So keep that in mind. Most of the time, passive range of motion is pretty much within normal limits and not irritable. However, there is more likely to be an issue with active range of motion. So they may demonstrate significantly decreased active range of motion, or alternatively, after doing that active range of motion several times, especially abduction, after they do that abduction movement several times, they could fatigue, and therefore you think it's a tear. And the other thing that we think of is if it's a big tear, they may also have decreased ability to do external rotation multiple times. So again, I'm not going to go into all the testing for rotator cuff. That's a separate class. But what you can recognize is that obviously we need to probably have patients that you suspect of having a tear do something like an MRI. And an MRI is obviously going to be the thing that really helps you decide whether or not there's a tear. So you can see here that there's different stages of tears. The top picture is a picture of kind of a cartoon, obviously, of the supraspinatus, showing you stage 1 where there's just a slight tear and it's pulling away from the bone slightly. Stage 2, you'll see it's now moved much more medially, so it's retracted even more. And then stage 3 is a full retraction. And you can see that to some extent in the pictures below as well. So the ones, this is MRI, stage 1, stage 2, and stage 3, where now that supraspinatus tendon in stage 3 there isn't any. So that subacromial space, there's no tendon, there's nothing in between the humerus and the acromion. So non-operative treatment. Certain patient populations and certain situations, patients will improve within 6 months. This is a hard one, you guys. I have to be honest with you. I've seen so many shoulders over the last 20 years. And I think it's nice if you can do conservative treatment, but the irritability level with conservative treatment is really high. And so if you could keep the irritability level down so that you can actually do conservative treatment, which is basically improving scapulothoracic rhythm and then strengthening the rotator cuff, if you can do that, then you're doing a great job. And again, we don't have time to go into all of the non-operative treatment stuff in this recording because there is a lot to talk about related to the surgery. But what I want you to recognize is the main goals are really to get that scapula in the right position, get the posture, the positioning correct so that they don't have pain with active range of motion, and then start doing strengthening. And if you can do that, and they can do it in a relatively pain-free range, then you're probably going to get good outcomes. If they can't, then it's a situation where I would say you need to go talk to a surgeon. And surgeons have different indications for when they decide to do surgery. So most of the time, if it's an athlete, they can't do their sport, they're going to do surgery. That's usually how it works with any type of injury, right? If they're under 50 years old, especially if they are relatively active people, which is most of the people that we know here in China, if they're under 50 years old, they're probably going to do surgery. If they're over 50, especially if they're active. So again, a lot of people are pretty active here. So if they're in their 50s and 60s, they may choose to do surgery. It's not terribly consistent. It kind of depends on the surgeon. But again, it's in America, they'll usually try conservative treatment for people over the age of 50 or 60. Initially, especially for a small or medium tear, and see how they do before they decide to go in and try to do surgery. And usually they'll try to do treatment for like 6 weeks. So again, shoulders are tricky and they can take a long time. So 4 to 6 weeks, I'd even say up to 8 weeks sometimes of therapy before you say, okay, this really isn't working. They're not able to keep that positioning, that posture. They're not able to do movement without pain. Okay, we need to go do surgery. If there's an acute tear, like an acute injury on a chronic tear or chronic injury, then they might choose to do surgery. Sleeping, as we all know with a lot of shoulder problems, is a big issue. People really have trouble sleeping. If it's really, really bad where they can't even lay down at night, they have to maybe sleep sitting in a chair or something, then they may choose to do surgery as well. So this says not responding to conservative treatment of 4 to 6 months. I think we probably would start considering surgery before that, but I'll usually say 2 months. Let's give this 2 months. And if we're starting to see a change, then we keep going. If we're not seeing a change at 2 months, then we probably will start thinking about surgery. So this kind of gives you like this is sort of like what they do with a massive tear. So again, with the other ones, we're really talking about smaller tears, but if there's a massive tear and it's an acute problem, so they've done the MRI, the patient maybe was a tennis player and did this crazy movement and totally just massively tore their rotator cuff. And so it's an acute issue, then they're definitely going to come in and do surgery. And they're going to do it as, they're going to try to completely repair the surgery as much as possible. Repair the tendon as much as possible. If it's more of a chronic problem, degenerative problem, so again, the older person with a massive tear, then they're going to choose to do rehabilitation probably first to see how it goes. And again, they're going to look at that maybe 8 weeks, 10 weeks, 12 weeks later, see if there's an improvement. If there is, then we're going to keep going with rehab. If there isn't, they're going to continue surgery. If they choose to do surgery on a massive tear, they may have to do some sort of salvage type of surgery where they're doing some debridement around the biceps. That kind of thing may be part of that salvage surgery. Again, these are these patients, these usually older people who have just a bunch of stuff wrong with their shoulder. And so they may have to debride the bicep tendon. They may have to go in and do a partial repair. They may come in and like try to reconstruct the capsule a little bit. And then they may even choose to do a tendon transfer. So if this is a significant tear where it's retracted a lot, like that supraspinatus we saw, they may not be able to have enough tissue there to pull and actually reattach. So then they have to go in and use something like the latissimus or the pec major to transfer those pieces of those tendons to do the repair. So we'll go through the actual repair here in just a little bit. We have a video so you can see what the repair looks like. These are other things that they may have to do with a massive tear. If they can't do one of those things, or they can't do a normal full repair like they want to, they may have to do a reverse total shoulder. So we've already, I think, gone through the reverse total shoulder, but that's kind of the other option that they have with a really bad tear. So if you've got those videos or you've got that information, you can go back and look at what you do for a reverse total shoulder. So this is some interesting research. It's a couple of years old now. They did a 10-year follow-up on a bunch of patients who had medium-sized rotator cuffs, small to medium-sized. So not the big giant ones, but the smaller ones. And they followed up in one group. One group did surgery, did a tendon repair, and the other one did physical therapy. And what they found was that actually the group that did have the repair had better outcomes at 10 years. Okay, so this is 10 years. They looked at them at baseline. They looked at them at 6 months and 1 year, and they're showing kind of their overall function. And you'll see at about 2 years or so, they kind of look the same. But then as you go to the 5-year mark and the 10-year mark, there is a pretty significant difference between the group that just had conservative care and the group that had a repair. And you'll see here when they separate these out that pain, I think, was a big piece of this. If you really look at this, there was definitely more pain in the group that had physical therapy versus the surgical group. The active pain-free abduction also was better. They had over 160 degrees in the group that had the repair versus under 160 degrees of abduction in the group that didn't. And for flexion, they both had over 160, but the group that had the repair had almost full. You'll see flexion, active range of motion. And then the thing that I think is actually probably in some ways more important is the strength. And you'll see that strength measurements for the tendon repair was much better. I think I would consider that much better than the group that just did therapy. So again, important to recognize this. This is long-term follow-up. So if you think your patient needs surgery, this is one of those that I would say go talk to the doctor about surgery. Okay, so we talked about some different possibilities for those large tears. What they tend to do with the smaller to medium tears, you can do an open surgery, so where they open it up and look at it, or arthroscopic. The techniques and the outcomes are pretty similar, and they tend to just go in and they either do like a single row or a double row of sutures, so suturing the tendon back together, usually right at the attachment site, and sometimes, like I said, they may choose to do an acromioplasty, so they're going in and like cutting through the acromion. They don't find that makes better outcomes necessarily, but they may go in and do that. So if they're ever going in to sort of resurface the bone, recognize that their patient is going to present with bone pain. So not only is the tendon pain that's always pretty bad, but they could also have that achy bone pain from having surgery on the bone. So just kind of keep that in mind as well. For the larger tears, again, we're hoping that they can repair, but they may have to do kind of a partial repair. They do find that there's like the double row of sutures gives you better outcomes. And then we talked about how they may do a tendon transfer from the latissimus dorsi. That's definitely a possibility, so that they can actually bring the tendon back together. And so for young patients, then using the latissimus dorsi, partial parts of that tendon can be really helpful. And then we talked also about the reverse total shoulder. So keep that in mind. There could be that possibility. I haven't seen a lot of reverse total shoulders in China, but I have seen a couple of them, and they were because the rotator cuff didn't exist. And so they needed to have that done. Okay, so let's look at the video here of what kind of the basics of what this looks like.
The most commonly torn rotator cuff muscle is the supraspinatus muscle. Small incisions are made to allow arthroscopic investigation of the damaged region and to allow the instruments to access the region. The damaged tissue surrounding the tear is removed, and frayed edges are trimmed and cleared. Holes are drilled and suture anchors are embedded in the bone at the natural attachment site of the tendon. Sutures are brought through the tendon and are fixed to the anchor sites. The shoulder incisions are then sutured.
Okay. So that's pretty straightforward. You get to see what those sutures look like. Again, hopefully that's the way that they can do it with most of the time. And again, that was a supraspinatus tendon. Remember, we can have injuries. Subscapularis, I would say, at least from what I've seen, is the second most common tendon that needs repair. And so, it's going to look exactly the same. It's just going to be on a different part of the arm. And then infraspinatus would be third. From my experience, teres minor would be fourth. So remember, oftentimes it's supraspinatus so it could be supraspinatus and infraspinatus, supraspinatus and subscapularis. So those things definitely happen. So again, you really want the op notes with this one because it helps you really see, okay, what did they do? Because a rotator cuff repair, we don't know what that means. That could mean a bunch of different things. We need to find out more specifically what they did. So complications. Stiffness. Oh, these patients, they get scared. They don't want to move. So stiffness is really, really common. Infection, maybe not quite as common. But re-tear is a pretty common problem. It happens pretty regularly if it's a large tear because, again, it's very hard to salvage the tendon and use that tendon. And so they have to kind of do other things like partial repairs. So for a large tear, it's much more likely to re-tear. If the tissue ended up getting fat in it, then it's much more likely to re-tear. If the space between the acromion and the humerus, so that subacromial space, is smaller, then again, you're going to have the higher likelihood that something like the supraspinatus is going to get impinged, and so then you're more likely to re-tear. If people are using narcotics or if they're smokers, so we all kind of joke about this, but smokers are definitely, more likely to have much slower repair time. It takes much longer, and they also are much more likely to re-tear. So when we say with, large massive tears, 21% re-tear, again, most of the time that's a supraspinatus that fails. But if they're having to repair more than one tendon, so maybe 2 tendons, 3 tendons, you're much more likely to have some sort of re-tear or failure. So if they had to go in and do 2 tendons, it could be up to 50% are going to fail somehow, so some re-tearing. Or if they have to do 3 tendons, up to 68% could re-tear or fail. So again, you need to keep that in mind so that you can be really careful, make sure you're really watching and monitoring how well these guys are doing with their rehab, especially if they have more than one tendon that had to be repaired. All right, precautions. Precautions for rotator cuff, I would say, are more important than not any other surgery, but they're very important with rotator cuff repair. So if you get to see your patients preoperatively, which we're going to talk about in a second, that's great, because patient education for this group is really, really important. You really want to make sure they know that they really need to have a sling, and they should have the right kind of sling, because that positioning of the shoulder after a rotator cuff repair is really, really important for allowing the tendon to heal correctly. And you can see the picture here of like a really, really perfect sling. I'm finding in China that the doctors are starting to educate them, or somebody's educating them on getting a sling, having a sling available immediately after surgery. So again, that they can position, you can see how she's got her shoulder positioned in this picture. You can be positioned correctly to put the supraspinatus or any of the other tendons in as neutral position, as open, packed joint position as possible, to allow for really good healing. So nothing is on stretch in that position of her shoulder. So you'll see that we put them in about 30 degrees or so of abduction. Every surgeon is going to tell you a different amount of time and how much they should be wearing the sling, but 2 to 6 weeks is pretty common. And so you'll see abduction and a little bit of scaption, I would say. So I would bring that shoulder forward, or that elbow forward a little bit, so you're not straight abduction. And then you really want to make sure that you're not going into any internal rotation. You don't want to be holding it into internal rotation, especially, obviously, if they have had surgery to the teres minor or the infraspinatus. So infraspinatus and teres minor, remember, those are external rotators. So if you're in any internal rotation, you're putting those on stretch, and then that can make healing really, really hard. So if they've just had the supraspinatus, it's not as big of a deal about the internal-external rotation positioning, but if they've had any other part of the rotator cuff repaired, you need to make sure that that position that does not go into internal rotation, that they are really respecting that positioning. So again, if you can see these guys pre-op, that's awesome, because you can practice the sling, you can kind of instruct them on using it. You can also kind of work with passive range of motion so that they're not really stiff or irritable before surgery. They can use the sling if they need to help with pain at that time. But again, you want to make sure they know how to use the sling after surgery. So that's really important. You can also teach them stuff preoperatively or immediately after surgery about how to put on clothes, because that's always really hard. And people here usually have help, but having them kind of figure out keeping that shoulder in a neutral position, how to get clothes on and off. You also want to find positions of comfort for sleeping. So that's going to be a little bit different after surgery, but before surgery, just working with pillows, finding ways that they can, again, kind of find as much of an open, packed, neutral position for their shoulder as possible. That tends to be the best for sleeping. And we'll talk a little bit more about that again with the post-op stuff, but that's something you can talk about pre-op. We also want to go through the time frame. So let's talk about the time frame. So this is something you want to educate your patients on, either pre-op if you can, or immediately post-op. So this is really helpful. There's a good amount of research about rotator cuff repair and just how long it takes. So what I would suggest is you can kind of either have this timeline, like just show them this slide, or set up a calendar. I think it's really nice to be able to pull out a calendar and say, okay, your surgery was on January 1st. 4 weeks from January 1st, on January 29th, you will be 20% healed. At this point, during these first 4 weeks, we're going to do passive range of motion primarily. And then at 8 weeks, which is the end of February, you will be about 40% healed. And at this point, we can get you out of the sling more regularly. You should be able to get your clothes on a little more easily. And then we'll have you doing more activities at about waist to chest level, but we're not getting up to shoulder level yet. But you can start doing activities at 8 weeks at that level, and we are 40% healed. At 12 weeks, which you would say would be at the end of March, okay, so now you're 60% healed, and you can start raising your arm up. You can go to shoulder level or even above shoulder level, but without any resistance. We really want to try to get at 12 weeks 100% range of motion if possible. However, at 12 weeks or the end of March, you should not be doing any overhead sports or anything like that, because that's going to be too much strain on the tendon. Over the next 3 to 6 months, so from the end of March until the end of June, we're going to continue to progress your strengthening and try to get you back to your normal activity. So this is kind of the normal time frame. And you'll see as we go through the rehab, the specific rehab, that this really follows for your kind of medium-sized tears. If they have the massive tears, then this time frame might be slower. So they may actually be slower than this. And so we primarily used this consensus of rehabilitation, this particular consensus statement from 2016, to work our way through this protocol for rotator cuff repair. But like I said, there's been research even in the last couple of months to show that you can start doing more active range of motion earlier than this protocol, and it does not hurt the repair. So I want you guys, we're going to follow this protocol from 2016. I think it's mostly appropriate, but recognize that there's newer research to show that if you start active range of motion a little bit earlier than this, that it's probably okay. I know people, the surgeons probably won't let you, so it's probably not even an issue, but just consider that the newer research is a little bit less conservative. Okay, so let's talk about phase 1, which is up to 4 to 6 weeks, just like we said in the previous slide. This is specifically for that small to medium cuff repair. And so our big goals during this period of time are to minimize pain. And pain with this group is really, really high. I just feel for these people, because I don't think there's any more painful surgery than a rotator cuff repair. I don't think there's any more painful injury than a rotator cuff injury. So if we can really minimize their pain and find ways to do that with positioning, with modalities, any of those kinds of things during this first phase, then I think that's a really, really helpful thing for people. We want to make sure that their scapula is working really well. So that's a big goal, is scapula positioning, making sure their scapula moves. And we can do that. There's that same picture again with that girl with the brace, with her sling. We can do that with this patient in the sling. Okay, so our patient education is, we want them to be using that sling with the abduction pillow for 2 to 6 weeks. And again, the surgeon may tell them a specific time frame, but basically that's the range. And they really should be basically using it all the time, except for when they're doing their exercises. And a lot of their exercises they can even do in the sling. You want to make sure they also understand their posture. So posture and positioning at rest, it really involves the scapula position. And then positioning for sleep. A lot of these patients are going to need to sit up for sleeping initially. So sitting in a chair, we use recliners in America. Recliners are not a big thing in China, but basically it's like a really, really comfortable big chair that's kind of like a couch. It's got all the cushioning like a couch, and then you can kind of lean it back. And people will oftentimes sleep, if they have a recliner, they'll sleep in a recliner for the first couple of weeks because they can't lay down flat. They can't lay on their side. They end up using a lot of pillows to try to kind of sit them up, which also works, and that probably is more appropriate in China. So they're kind of in a sitting position, and that tends to be most comfortable initially for sleeping. We want to obviously avoid active range of motion at this time. Like I said, there is the newer research that says it might be okay, but we really want to try to avoid any muscle contraction, active contraction, which obviously you need with things like flexion and abduction and those movements that we know. But we really want to try to avoid that for about 6 weeks, which, again, that seems like a long time, but remember, this is a tendon. Its tendons need to heal. And so if we have too much power through the tendon, then we're more likely to cause a tear. So our exercises with the first phase, it's a lot of posture stuff. It's a lot of postural awareness and exercises. You can do stuff for the hand, right? So you can grab the ball, do stuff, make sure the hand's moving, do resistive stuff with the putty or whatever. And then you also want to make sure that range of motion is really good. Active range of motion is really good at the wrist and hand. So that's why I'm saying you take them out of the sling. You make sure the wrist and hand are moving really well. You make sure the elbow is moving really well. So you're getting full extension of the elbow. So that's a big one, is that, they get stuck in the sling for too long and then they end up with an elbow contracture because they didn't extend their elbow for long periods of time. There are suggestions for pendulums or the Codman's exercise. I have to be honest with you, I hate pendulums because they're almost impossible for people to do right. So there's a picture there of pendulums where the lady looks like, she's just kind of letting her arm hang and moving it around passively. But most patients are going to turn on their muscles. They're going to totally turn on their muscles. So it's really, really not my favorite exercise, those pendulums. If you can get a patient to use their hips and really relax their arm, then they're okay. And if we are going to be able to do a live lab together as a group somehow for teaching, I can show you guys what a pendulum should look like. And then the other big thing, as I mentioned earlier, scapular exercises. Scapular exercises in the sling. So making sure that the scapula is able to move in all directions, especially protraction and depression. But you can also do elevation. You can also do retraction. Just make sure it's moving. Manual therapy. You're going to be doing passive range of motion at the elbow and wrist if you have to, if they don't have full range of motion. And for the first 2 weeks, your shoulder is passive range of motion only. And sometimes they would even say longer than that. So first 2 weeks, passive, passive, passive only. And then at week 2 or 3, you might start doing a little bit of active assistive range of motion using a cane. So like with scaption or a little bit of abduction and just going to like 60 degrees, not very high. That picture shows her going to 90 degrees. Do not do that yet. You are doing very small ranges. You'll notice doing them in supine. Supine tends to be more comfortable. So laying on your back tends to be more comfortable because the scapulas don't have to work so hard. So, and you're not working as much against gravity. So you might find that this position is easier for patients initially. For rotation, same thing. So internal, external rotation only to 30 degrees, guys. You're not pushing past 30 degrees, okay? And it's active assistive range of motion. There should be very little muscle contraction, okay? And no pulleys. I want to make sure you understand that there's those crazy little pulley things that are in all of the outdoor, like, play areas or whatever with all the equipment. And people love to do pulleys. But the problem is the pulleys, they found in the research, we turn on more muscles around our shoulder doing pulleys than we do with things like putting a shirt on. So we have to be kind of careful with pulleys that we don't overuse the muscle groups. So don't do pulleys. For active assistive, stick with the cane. And again, if you want to try to do those pendulums that we talked about, the Codman's exercise, you certainly can if the patient can do it right. And if it feels good for them to kind of relax the arm down and swing it around, that's fine, but they cannot be turning on the muscle. So progressing out of phase 1, the big thing is pain control. These people, you need to develop trust with them, okay? You need to develop enough trust that they can get their muscles to relax so that you can do passive range of motion. You really want to try to get passive range of motion up to 120 degrees of scaption and 20 degrees of external rotation. So those are kind of good milestones to move from the first phase into the second phase for these small tears. But it's really, really hard to do that without pain for many of your patients. So those of you who have worked with me, and again, if we have a chance to work together, you can dance with the arm. So I will get that arm really, really close to my body and kind of just move my hips around and just kind of, like I said, dance with their arm to try to get the muscles around their arm to relax because they're oftentimes in total spasm and fighting you like crazy. And I'll do that for the first couple visits. I won't even try to do any passive range of motion per se, and start with that and then start to move into movements passively, because if I try to do the passive range of motion the first visit or two, it's just scary and they're in so much pain and they hate me. So we don't want our patients to hate us. I highly recommend going slow and finding ways to do mobilization without pain or with as little pain as possible. But because remember, they're going to have pain. It's really hard to avoid any pain. So for the larger massive repair, you'll just see the time frames longer. It's 8 to 10 weeks. It's a very, very similar, we're doing very similar things in phase 1. We're just doing them for a longer period of time. So we really, again, are trying to minimize pain as much as we can, minimize stiffness, make sure the scapula is doing what it's supposed to do. We're still wearing the sling. This says 2 to 6 weeks. It's definitely going to be closer to 6 weeks, maybe even 8 weeks for some of these patients. But you'll see that the patient education is the same. It's the same for both groups. Our treatment is a lot of posture stuff. It's a lot of posture and then doing stuff for the hands. Again, it says pendulums here, which is not my favorite thing, but you're going to be doing also those scapular exercises. And then you'll see the last thing is if they did have to have their bicep repaired with the rotator cuff, or if they just did a bicep repair on its own, you want to avoid anything that would turn on the bicep for at least this first phase. So that would be obviously elbow flexion, like active flexion, and anything with a ball squeeze that's going to, that turns on the bicep. A lot of people, when they squeeze a ball really hard, you can try it yourself right now. If you squeeze your fist really hard, you'll turn on your bicep. So if there was anything related to the bicep getting repaired, you need to think about making sure the bicep is turned off during this first phase. So manual therapy is the same. You're going to do passive range of motion where you need it, which could be wrist, it could be elbow, it could be shoulder. And then you're going to start moving into active assistive range of motion after that point. And really, our milestones are the same. So we want their passive range of motion to be about 120. But again, it's probably not going to happen until about 8 weeks. And their external rotation, 20 degrees. And again, think more closer to 8 weeks. For the small rotator cuff tear repair, you're usually starting this one at about 4 weeks and going until about 10, maybe 12 weeks. So this is about 2 months or so, between 6 and 8 weeks. And with this one, our goals are to be able to get between 90 and 120 degrees of essentially overhead movement. So not full. You're not getting full range of motion at 3 months, okay? Keep that in mind. We're staying below that range of motion, and that could be passive range of motion, right? Between 90 and 120 degrees. External rotation, 70 degrees, okay? That's kind of a lot, but it's important that we're getting to that 70 degrees. External rotation is really important. Internal rotation to 55. Pain control, huge for this group. And we really want them to be able to keep their humeral head in the right position. So it's a lot of postural stuff. Again, we talked a lot about the scapula in the first phase. We want to get that position of the humeral head more posterior, and maybe even a little bit externally rotated, so that, and really to do that, you end up using a lot of your scapula positioning to get there, and that will keep the humeral head in a better position, again, to allow for those tendons to heal in the best way possible. So, no big movements, no big gestures, no fast gestures. You really should not be lifting, loading. So you should not be doing what's in the picture. She has this big, giant, heavy walk in her hands. That is not something you should be doing. You should not be lifting heavy things at all, pushing or pulling at all during phase 2. Anything that you want to do below shoulder level that's functional, meaning putting on your clothes, lifting light objects, that's fine. But then our other big thing is we want to be able to get her their active range of motion back without compensating the movement. So the movement pattern is really important. A lot of these patients, before they had surgery, especially the patients where it was a degenerative tear, so not a trauma, they probably were having movement patterns that weren't appropriate before the surgery, and that's what led to the tear. And so you really have to make sure that they're not compensating with their upper trap. They're not compensating by turning on their internal rotators too much of the shoulder. You really want to make sure that they have really good scapula position and they're turning on their muscles correctly with the active range of motion that they're practicing. So, for treatment specifically, we are doing the active assisted range of motion with the cane. We keep those up, okay? We can now start doing more active range of motion using maybe the wall, or a towel on the wall, or a towel on a mat or something that slides, so they can start sliding their arm up a wall or along a table, something like that, only to 140 degrees. So you're not going to do full range of motion here. 140. You can also start some sub-maximal isometrics. So once they have 80% of their range of motion, they need to have their range of motion first, people. At least 80% of that scaption, flexion, abduction, external, internal rotation, you can start doing isometrics. And so these isometrics are sub-maximal. You're not going to 100% muscle contraction, but you can start doing some contraction. So if you're going to do flexion, make sure when you're doing flexion, they don't have they didn't have surgery to their biceps, right? As long as they didn't have surgery to their bicep, doing flexion isometrics is fine. You can also do external and internal rotation isometrics, but you need to make sure that they're not in adduction, right? You need to have a little bit of abduction and put them in that abducted position, kind of like the picture with a towel roll or something, before you start doing any isometrics with external and internal rotation. You can also do some closed chain scapular exercises, so meaning like the hand on the wall and actually turning on the scapular muscles that way. And then you really want to make sure they're doing some sort of cardiovascular activity. So either bike, elliptical, something that's keeping them moving, keeping them just kind of in good shape, right? So you can do joint mobilizations in the second phase, but stick with grade 2 or 3. So kind of gentle. I usually tend to use them more for pain control, to kind of move the joints. If they're really, really stiff, you can certainly consider using them more to decrease stiffness. And so that's fine. You're obviously continuing to do passive range of motion. Hopefully they're tolerating it better by now. You can also do some scapular resistive exercises. So I love PNF for the scapula. So you can play with that, or other things that would give resistance specifically to the scapula. And then if you need to do manual therapy for the scar, obviously do that as well. So our milestones to get out of phase 2 for these smaller tears is that they have really good scapular control and they have really good resting posture. So that usually has a lot to do with scapular control, so that they can hold their shoulder in a neutral and a good position. And they can keep it there when you're doing your range of motion. And if you started doing some isometric activities, that they can keep that shoulder in the right position with the isometric activities. For range of motion, active range of motion, they should really be able to do flexion or scaption like 30 times. Again, not full range of motion, but maybe to 90 degrees, 120 degrees, 30 times without using substitutions, without using their upper trap. Same thing with external rotation. They should be able to do external rotation, maybe not all the way to full range against gravity, but 30 reps, inside lying, no weight, external rotation, again, maybe to 45 degrees. So large tears, it's going to go from about week 8 or 10 up to week 18. So this is over 4 months, guys. These guys are moving slower, okay? Our goals. Oh, look, they're the same. They really are the same. Same goals as with the other group. Nothing that moves too fast, no lifting. You can start doing functional movements below shoulder height. So you can reach for a glass. All that kind of stuff is fine. Our treatment, we're sticking with the same treatment. So you're doing those cane exercises. You can start playing with the towel on the wall or the towel on the table. You're doing your isometrics, you're doing your closed chain, and you're doing some sort of cardio. Manual therapy, again, it's the same. We're just putting in those slides again. You're doing your grade 2, 3 mobilizations if you need to for pain control, also if there's significant stiffness, and then doing passive range of motion as long as, and really trying to be careful with pain. So milestones to progress, again, the same with this group. It's just going to take longer. So don't expect their endurance to be quite as good. Expect that flexion 30 times and external rotation 30 times is going to take longer to get there. So phase 3 is where we can start doing more stuff. And so for those small tears, you're starting this at about 3 months, going just 4 months or so, or not 4 months total, but 4 months total. So like for 1 more month total. And for this one, you really want to get like range of motion. So overhead should be over 160 degrees. Your external rotation should be full at 0 degrees of abduction and 90 degrees of abduction. And then you're really starting to focus on increasing strength, especially with external rotation, because even if the external rotators were not repaired, external rotators tend to be weak. And again, this is usually something that the patients were experiencing before the surgery. So now they're coming back and they probably are having issues with weakness after the surgery that were even worse than before the surgery. So even at this point, so again, this is up to 4 months after surgery, you don't want to be lifting overhead. You don't want to be lifting really above shoulder level. You still want to be careful about pain. So if they're having pain, you need to reassess and make sure that your shoulder's in the right position, that your scapula is in the right position, and then try the movement again. But you shouldn't be doing movements with pain. Lifting below shoulder height is totally fine, but not higher really, especially things that are heavy. And we really should be able to get full normal range of motion at this point. Exercises, active range of motion, overhead with that wall slide. So if you're doing wall slides with the towel or, like the finger ladder or something like that, you should be able to get full range of motion all the way to the top. You can also now start doing isotonics for the rotator cuff. So you can start doing resistance through range of motion. So you could use TheraBands, you can use weights, you can use rhythmic stabilization. So something like the body blade. I love the body blade. That's a great thing to start playing with during this phase. And then really start pushing your scapular exercises as well. So you can do resisted like rows, but then you can also do ball stabilizations. Anything that's weight bearing for the arms is good to be doing at this point. So push up plus, and then you see like the wall slides there with some resistance and external rotation. Those are all great exercises during this phase. Again, this is the like month 3 to 4 for those smaller tears. Yes, so those, again, weight-bearing proprioception exercises is a great way to go. Continue doing your cardiovascular stuff. And then for manual therapy, that says closed chair proprioception exercise. I'm sorry. That should be closed chain, obviously. Sorry about that. You're like, closed chair, what's that? Closed chain. And maybe it says it right in Chinese, but it doesn't in English. If you need to do manual therapy, you can do mobilizations at higher grades, so like grades 3 to 4, and then you can also be doing stretches at this point. But keep your stretches gentle. Remember, when tendons are healing, we don't want to overstretch because we could end up with a tear. So we'll talk about that a lot with things like Achilles tendon repairs. But with this one, just gentle stretches to make sure the soft tissue is moving, especially for internal rotation, because that tends to be what gets tight. So we want to play with internal rotation. Functional internal rotation, as you guys know, is the hand behind the back. So you want to make sure that you are doing that and practicing different ways to get better internal rotation. So we really should have full range of motion by the end of phase 3. We also are strengthening in phase 3, and we should probably have like 3+ to 4- as our strength numbers to consider at the end of phase 3. Also, we should have endurance, that they should be able to hold something like external rotation at 45 degrees for 1 minute or internal rotation at 90 degrees for 1 minute. So that's kind of easy ways to measure their rotator cuff endurance. Also, you want to make sure that they can do motions up like 50 times before you increase before you increase the weight. So it's really important that they're doing those motions right. Like we talked about 30 times for phase 2. With this one, I would say up to 50 or 60 times that they're doing a motion, either with some resistance or no resistance, depending on what they can tolerate. They should be able to do it 50 or 60 times before you increase their weight. Sounds like a lot, but remember, we've got to think about endurance. And with the strengthening can come a little bit more slowly. So our large tear group is going to be 18 weeks to 24 weeks. So 6 months, guys, 6 months for phase 3, okay? So that's a long time. This stuff is all the same. We want their range of motion to be almost full range of motion, and they also should have better external rotation strength. All of this stuff is the same. Treatment is the same. Treatment is the same. Closed chair, proprioception exercise. Closed chain. Okay. And milestones. Milestones are the same. So for sport-specific training, usually starting 4 to 4.5 months for the small tears. And this is where we really should have full pain-free range of motion. We can start doing more functional activities over shoulder height, and we can start doing more plyometric training. So you can see that they're doing the push-up with the clap on the little picture there. And really the goal is that we're getting back to the athletic activities that they like to do. So if they were doing tennis, we're getting them back to tennis. If they were doing swimming or badminton or whatever, we're getting them back to that. And we really want, for return to sport, we want their strength to be, isokinetic strength to be within 15% of the uninvolved side. So 15%, if you can test that isokinetically, awesome. If you can't, just do your manual muscle test. They really should be pretty darn close to each other for external and internal strength, external and internal rotation. And they should have pain-free range of motion, pain-free, active range of motion, within 10 degrees of the other side. Pain-free, important. And the other important thing is, for their rotation, their range of motion should allow for them to do their sport. So if they are a tennis player and they have to be able to serve, then they have to be able to get that arm behind their back and throw the ball up in the air. And that's going to require probably more external rotation than somebody who, is going back to a sport that doesn't, require the same kind of movement. Same thing with swimming. Think about how much extension and external rotation they need for certain things. So you need to make sure that they've got that range of motion that's pain-free before you start adding resistance and getting them back into the sport. So we're doing a lot of strengthening, a lot of endurance type stuff, and, just whatever you guys like for upper body stuff. Again, think sport specific. You can do lots of plyometrics. Like I said, I love the body blade. You can really play with the body blade during this period of time, doing lots of throwing, and make sure you're not forgetting about the scapula, because the scapula can help to drive those movements pretty well. So just, again, large tear. I don't know how many of them are really going back to sports, but if they did have a large tear, it could take up to a year before they even get to be able to go back to a sport. So just keep that in mind. It's going to be a slow road. And so the activities are the same, and, we're doing the same things. We have the same goals. We want them to be able to be, the strength needs to be within 15%. Active range of motion needs to be, really close to the other side. And they really should not show, if you were to do testing of rotator cuff, with things like the full can test, the near test, those kinds of things, they really should not have any positive tests when you test them. Okay, so exercises are the same as with the other group. Okay, guys, this was a long one. I could have talked about this one. I mean, we could do like a whole day on rotator cuff, right? So we're just trying to give you, again, the most clinically important things that you need to really be aware of when it comes to rotator cuff repair, and that's the timeline, and understanding the timeline and the why with the timeline.